Yeah. Coming to systemic conditions in pregnancy. First thing we are going to discuss is thyroid disorders in pregnancy. So now tell me, coming to a normal pregnant female. So we are not discussing either hypo or hyper. So normal pregnant female, what is going to happen to TSH? Increases, decreases, remain same, or increases in early trimester, decreases in early trimester? So for your as per as your knowledge, for your PG preparation knowledge, just remember, for gynec knowledge it is a bit depth. In first trimester it varies, second trimester it varies, in third trimester it varies. Why first trimester it varies? Can anyone of you tell me first trimester it alters, but why? Because of which hyperplasia? No, not because of hyperplasia. TSH will mimic which hormone? Beta HCG, alpha HCG. Okay, normally, so a bit it will be altered. So which are the other hormones which mimic alpha? FSH, LH, TSH. So a bit it will be altered in first trimester, but not. But for your sake, don't remember that. For your sake, remember TSH is unchanged in pregnancy. So for your sake, your knowledge, they'll never ask you in first trimester, second trimester. They have asked you either it is increased, decreased, or unchanged. So rest of the times it remains unchanged. So normal pregnant female, it remains unchanged in pregnancy. Is TSH going to cross the placenta? Heparin, does heparin will cross the placenta? Heparin will cross the placenta or no? Does propylthiouracil will cross the placenta? What is propylthiouracil? Where do we use? Okay, propylthiouracil. Does it going to cross the placenta? Methimazole either is going to cross or not? Crosses. Propylthiouracil? Then why a baby develops neonatal thyrotoxicosis? We'll see. So these are all the questions asked for you. We will discuss. At the end you will know which is going to cross, which is not going to cross. Yeah, Shan, you are right. Okay, coming back to our topic. So it remains unchanged in pregnancy normally. Why it is very important that thyroid disorders are, they are going to decide the development of the fetal brain and the mental function. That's why we are worried about the thyroid disorders. But remember, TSH is not going to cross the placenta. TSH will not cross the placenta. And coming to T4, free thyroxine, it is always the free thyroxine. We are not discussing the bind form, okay? Free thyroxine and TSH, these two, free T4, especially the free T4, they are going to remain unchanged in the pregnancy, okay? Remember, free, we are not discussing about the bind component, bond component. It is free T4 which remains unchanged. What is going to happen to globulins? Thyroid binding globulin, always all the globulins, liver, it is going to increase, okay? Even so, that's why the thyroid binding globulin also going to increase in pregnancy. So free TSH and free T4, they are not going to change. How to differentiate? What is subclinical hypothyroidism? Normally hypo TSH will be increased or decreased? Hypo increased. What is going to happen to T3 and T4? In subclinical, what is difference between clinical and subclinical? Which is T3 or T4? Which one you want to go for? If you want to go for one thing. T4. Coming to, okay, I will tell you that also. Coming to hyperthyroidism. Hyperthyroidism, this was asked for you. What is the most common cause of thyrotoxicosis in pregnancy? It is Graves' disease. So Graves' disease, which is the most common cause of hypothyroid in pregnancy? So most common cause of thyrotoxicosis in pregnancy is Graves' disease. So why we are worried about this Graves' disease is any patient going for cesarean section or any infection, or if the patient is in labor. So these are all the precipitating factors. Still the patient may land in chances of thyrotoxicosis. So the level should be controlled. So what is the treatment normally for hyperthyroidism? What is the antithyroid drug you want to give? The drug of choice. So propylthiouracil. What are all the other alternatives other than propylthiouracil? Carbimazole, methimazole. So which one you want to give? Carbimazole, methimazole? Why? Fetal Aplasia cutis. Remember this term. Aplasia cutis. So once you give these drugs, methimazole carbon, they are going to cause aplasia cutis. So the most common side effect with these drugs, antithyroid drugs. So other than that, what are all other treatments? Okay, very good. Propranolol. If it is severe tachycardia and all, you will control with propranolol. Next, radioactive ablation. You want to go or not? If you want to go, you want to do it in which trimester? Radioactive ablation is totally contraindicated. It is radioactive. So baby is inside. No radioactive things. So remember, radioactive iodine should never be given. So ablation with radioactive iodine is totally contraindicated in a pregnant woman. Not only in any first or second. In all trimesters, it is contraindicated. Yeah, Bibu, you are right. So propylthiouracil, it is the drug of choice. So the drug of choice in thyroid hyperthyroidism is propylthiouracil. What is the main mechanism of action? Only conversion. So thing is, it inhibits the conversion of T4 to T3, and propylthiouracil small amount will transfer across the placenta. That's why the fetal complication, goiter is seen, fetal goiter is seen. Okay, remember this. Propylthiouracil is also going to cross the placenta. This was asked for you. So which of the following drug is the cause of the fetal goiter? Out of that, one option was propylthiouracil. So remember, propylthiouracil is going to cross the placenta and going to cause fetal goiter. Some amount is going to cross. Okay. Methimazole readily crosses placenta. That's why you never want to give this methimazole, especially associated with aplasia cutis. Suppose you have given medical management, it failed. What next treatment? Surgery. You want to do surgery in a pregnant female? Can we do surgery? Radioactive iodine, we have said it is contraindicated. What about surgery? Can we do or not? So surgery can be done. Okay. Radioactive iodine is contraindicated, but not surgery. Always remember, any surgeries in pregnancy always in second trimester. Okay. Either suppose they will give ovarian cyst. If you want to do surgery at which trimester? It is second trimester. Okay. So any surgery always in the second trimester. So for women who fail medical management, we are going to proceed with thyroidectomy. Complications. What are all the complications? Hyperthyroid. So coming to hyperthyroid complications, hyperthyroidism, we know it is going to cause heart failure. Other than that, the chances of hyperthyroidism and preeclampsia are interrelated. Remember this point. Okay. Hyperthyroidism and preeclampsia. So there can be preterm birth, stillbirth. This is and neonatal thyrotoxicosis. Okay. 1% is due to placental transfer of thyroid stimulating antibodies. Even this is going to cause. So what are all the things which are going to cause? TSH, will it cause placenta? TSH is not going to cause. Antibodies, they are going to cause. That's why they are causing neonatal thyrotoxicosis in the baby. So even once the baby is delivered, the baby should be monitored for this antibodies. So why the fetal goiter? From propylthiouracil. Sometimes it will transfer. This was asked for you in All India. So complications other are preterm delivery and stillbirths. What is this thyroid storm? So it is a life-threatening condition. Thyrotoxicosis patients. The most common dangerous thing is their patients land in heart failure. So most often associated with heart failure. What are all the things we use in such a condition? Sodium iodide, but and beta blockers to control tachycardia. Okay. Dexamethasone we give to inhibit peripheral conversion of T3. What is the mechanism of action of sodium iodide? Propylthiouracil, what is mechanism of action? Okay, T4 to T3. It inhibits the release of T3 and T4. Okay, remember this mechanism of action was not asked for you in gynec but in surgery. So sodium iodide, it is going to inhibit the release of T3 and T4. Hypothyroidism. So Hashimoto's, what is the most common cause of hyper? Graves. Hashimoto's. This is the most common. So how to differentiate this subclinical and overt hypothyroidism? So subclinical hypothyroidism is more common. So in coming to overt subclinical hypothyroidism and overt hypothyroidism, in both TSH is increasing or decreasing? TSH is increasing. Coming to free T4, whereas in clinical, if you are able to see clinically, it will be decreased. In subclinical, normal. That's why we make a cutoff of 10. Okay, normally if the normal greater than 5, it will be abnormal, the TSH levels and all. Suppose if it is in between 5 to 10, if the patient is symptomatic, then we put the patient on treatment. If the patient is asymptomatic, we are not going to give any treatment. And to confirm it, for that we are also going to do free T4 and normal. The free T4 is normal, it is subclinical. If it is altered, it is overt hypothyroidism. Treatment, what is the treatment? Levothyroxine replacement. So once you give thyroid, how often we ask the patient to come? 3 weeks. 3 weeks? How many weeks? After how many weeks you want to repeat the thyroid test? 3 weeks or 3 months or 8 weeks? No, anni ikkada juice cheptunu. Andike nenu tappu pedtanu. So normally it will take 3 months time. Okay? So normally 3 months approximately. I mean, minimum is 2 months. If your books, it is 3 months. Remember as 3 months. So all the books is, it is 3 months minimum time which it is required for the hormones to take control of the body. So after that we recheck it. So once a patient on thyroid, how frequently we do? First trimester, second trimester, third trimester. Remember like that. So every 3 months we will do it. So it is TSH is monitored every trimester. What are all the complications in thyroid? So this was asked for you. So just now we have discussed thyrotoxicosis patient can have cardiac dysfunction, so cardiac failures. Other than that, preeclampsia we have discussed thyroid with preeclampsia patients. So sometimes preeclampsia abruption can be there. Other than that, low birth weight and stillbirths. Yeah. We have finished thyroid. That's it, thyroid. Coming to respiratory disorders. Normally respiratory disorders. So always a pregnancy is a hyperdynamic circulation. So the respiratory rate is going to increase or decrease? Oxygen demand is going to increase or decrease? Increase. So oxygen demand, the respiratory rate, everything is going to increase in pregnancy. So what is going to happen in an asthma patient? The asthma was asked for you. So there are sometimes increased complications, asthma. So the main why we are worried about asthma patient is mainly IUGR. The oxygen supply to the fetus is compromised. So the most common fetal complication is IUGR. So this was asked for you. 25, 25, 50. Remember these values. So a patient previously asthmatic, now she became pregnant. What is going to happen? Either it is going to improve, either it is going to worsen. This was asked for you. So 50% no change. 25% will improve, 25% will worsen. So one more value is there in other disorder, I will tell you. So in asthma, what is the values? What is going to happen? So remember these values, epidemiology, regarding this. So treatment, normally, can we give steroids in asthma patient? In pregnancy. In pregnancy, can we give steroids? So the asthma treatment is same even in pregnant women, no other alternative. So as if like a non-asthma woman, we are going to give. So the drugs include beta agonist, epinephrine and inhaled steroids, same. So beta agonist we are going to give salbutamol and all, okay. The same drugs we are using. And one more very thing we are worried about is treat about respiratory tract infections. Coming to pneumonia. So why we are about a patient with pneumonia? A patient lands up with severe respiratory distress. Most common cause is pneumonia. So if a patient, antenatal woman has pneumonia, what should be worried? The preterm labor, premature rupture of membranes. Okay, the high risk of preterm labor, patient landing in. How to diagnose it? Only by chest X-ray with an abdominal shield to confirm the pneumonia. So pneumococcal vaccine. Can we give vaccine? Pneumococcal vaccine. Patient is developed pneumonia. Now you want to give vaccine in pregnant women. So live vaccine. Never give a live vaccine in a pregnant woman. Always pneumococcal vaccine is contraindicated because it is a live vaccine. But there are certain conditions where we should give pneumococcal vaccine in pregnancy. So what are all the conditions? Where the patient is in immunocompromised state or having severe cardiac, renal or pulmonary disease. Okay. In such a condition, pneumococcal only we can give in pregnant women. Only in pregnancy pneumococcal. Because the patient will land in pneumonia, severe pneumonia, they are going to land in severe pneumonia, finally preterm labor, the risk is very high. So only in such a conditions only we can give, not normally recommended, any live vaccine not. Can we give rubella vaccine? Measles? Mumps? Measles you want to give? Mumps? Hepatitis? Hepatitis, that is homework. Can we give hepatitis vaccine or not in pregnancy? Next class you should tell me. MMR we are not going to give because measles, mumps and rubella are live vaccines, remember. But hepatitis can we give in pregnant women or not? Can we give rabies vaccine? Patient, she came with a dog bite. Can we give rabies vaccine? Rabies given or not? Kuka gachindani ochindi patient, you want to give or not? Until you will give rabies vaccine in pregnancy. Rabies, yes or no? Online answer, you want to give rabies? Yes, rabies vaccine should be given in pregnancy. Don't wait until her term, her delivery, then give rabies and meanwhile she'll land, okay? So rabies vaccine can be given in pregnancy. Tell me tomorrow, that is your homework. Anni nenu chepte meer chadavatledu. So hepatitis can be given or not? Which vaccines are contraindicated in pregnancy? So normally for bacterial pneumonia, erythromycin we give, okay? Severe, this was asked for you. Remember the antibiotics, even the antibiotics were asked for you. So which of the following, PJ, this was a PJ bit. So which of the following antibiotics can be given in a pregnant woman in a patient with pneumonia? So this, yeah, it is amoxicillin. Normally the beta-lactams can be given. Cephalosporins also can be given. Aminoglycosides can we give? What is side effect? Ototoxicity, nephrotoxicity. Aminoglycosides never to give in it. Ciprofloxacin and ofloxacin. Quinolones can we give? Quinolones can we give? Ciprofloxacin, ofloxacin. So never to give even quinolones, aminoglycosides. So remember what should not be given. You can't remember. So remember what can be given. Only 2 drugs are given. Penicillinase group of drugs. Okay, ampicillin, clavulanate, like that group of drugs can be given. And cephalosporin. These 2 drugs are safe. Can azithromycin be given? Azithromycin, which group of drug? Macrolide. Can azithromycin be given? Azithromycin. Erythromycin. Erythromycin we can give. What about azithromycin? Azithromycin can also be given in pregnancy. Remember that. Okay. But not quinolones, aminoglycosides. So this was asked for you. And MRSA, vancomycin. Coming to renal and urinary tract disorders. So we have finished regarding only whatever is important and whatever was repeated for you I am discussing. Okay. Whatever is important, I don't want to give you in detail as if like a gynec PGs. Okay. Just only whatever is important for you. Coming to renal and urinary tract. What are the pregnancy normal physiological changes in renal tract? Vivek. Physiological changes in renal tract. Meeriddar Viveka. Increase GFR, increase renal blood flow. Only 2 findings. What is asymptomatic bacteria? Less than 10 power 5. Less or more? What is asymptomatic bacteria? So simple question. Is it less or more? Why there is a lot of confusion between less and more? Asymptomatic bacteria. Is hydronephrosis seen in a pregnant woman? Physiological or pathological? Hydroureter? If it is common on which side? Why? Why? Yeah, you are correct, it is right side, but why? Yeah, very good. It is most common on right side. This was asked for you because of dextrorotation. So the uterus is compressing the ureter on the right side because the most common is right side. So most of the times the uterus is be on the right side. It will be the compressed ureter. So the hydroureter and all more common. What are other physiological changes? Vizag, you are right. Bibu, you are wrong. What are other features? So progesterone, what it is going to do anywhere, either the uterus or bile or wherever it is there, it is going to decrease the tone. So automatically the urethral tone is going to decrease. So the chances of infection, one more, here it is compressing, so the reflex will be more. So the chances of infection to the kidneys. That's why a patient, normally it's very typical presentation, the urosepsis, if the patient dies in because of this septic condition, it is most commonly due to urosepsis. So the most common complication of this pyelonephritis is urosepsis. The patient is going to die because of that. So we'll see. So pregnancy causes hydronephrosis. It is normally a physiological phenomenon. So dilatation of the renal pelvis, calces and ureters, more common on right. We have discussed why it is more common on right. Normally the tone is going to decrease, and because of this compression it is going to cause urinary stasis, and because of this decreased tone there will be urinary stasis. At the same time increased reflex leading to the infection automatically goes to the kidneys. What is this asymptomatic bacteria? Remember this, in asymptomatic bacteria how much percent will develop pyelonephritis? This was asked for you. So in asymptomatic bacteria, if you are not going to treat, 25% will land in pyelonephritis. I know one of my friends, she immediately landed in pyelonephritis. She was hospitalized for around 1 week. Then during hospitalization, she was diagnosed as pregnant. So that is how the asymptomatic bacteria presents. So once the asymptomatic bacteria, 25% will land in pyelonephritis. It is called as asymptomatic bacteria in recently married is called as, if there is infection, urinary infection in recently married women, it is called as recently married women urinary infection. Honeymoon cystitis, it is called as honeymoon cystitis. So always any woman, what do you mean by asymptomatic bacteria? Patient will not present to you with any symptoms. Patient is totally asymptomatic. On examination, so what examination? Only culture sensitivity will detect bacteria, okay? Not even routine complete urine examination. So every woman with initial visit you are going to screen this. So pyelonephritis, it is the most common serious medical condition. Previously I told you. So it is most of the times it is unilateral and right side. We know already why it is right side. So what is the most common organism? E. coli. Other than E. coli, what are other organisms? Klebsiella. So E. coli, Klebsiella are most common. Most common out of both these two is E. coli. So there can be even bacteremia in 15 to 20%, sepsis. So complications, what are all the complications? Remember this ARDS, this was asked for you. So a patient with renal pyelonephritis, why we are very much worried about is not even about sepsis. So the patient, because of the toxins, whatever they are released, they are going to cause ARDS. So the most dangerous complication in a patient with pyelonephritis is ARDS. We are worried about this ARDS because of this endotoxin induced alveolar injury. So other things are renal dysfunction, automatically creatinine levels are increased, preterm labor and hemolysis. These are all the other complications. Differential diagnosis. So patient presents with pain abdomen. That's it. Not other, no other symptom. The patient once presents with fever, pain, tachycardia. One thing is, what do you think? Fever, pain, tachycardia, pregnant lady, chorioamnitis. Most common thing just now we have discussed. So chorioamnitis. Other than that, the pain abdomen, appendicitis, cholecystitis. Okay. And preterm labor, sometimes infected myoma. So how do you manage? IV antibiotics, that is cephalosporin group of drugs which are safe in pregnant. And suppose if the patient is having recurrent pyelonephritis, long-term antibiotic suppression. Which drug you want to give? Now nitrofurantoin, we give nitrofurantoin, okay? That is for especially for urinary tract infections, daily one tablet. Coming to gastrointestinal disorders. So patient presented with acute pain abdomen. What are all the differential diagnosis? Cholecystitis, appendicitis, rupture uterus. Okay. Rupture uterus, what is the typical case scenario? The patient presents with typical case scenario. What did I tell you? Rupture uterus. Before that, severe. What complaint the patient will have? I am not asking about signs, I am asking about symptoms. The typical case scenario, the patient comes to you. Sudden cessation of the pains, That is rupture uterus. Until now the patient says I had severe pains, but suddenly the pain stopped. Okay, now she's totally cool, no pain abdomen. That is rupture uterus. Okay, severe contractions followed by sudden cessation of the pain. So that is a patient with rupture uterus. So what are all the DD? Pyelonephritis, appendicitis, pancreatitis, cholecystitis, and remember ovarian torsion. This is also most commonly seen. You forgot our topic, ectopic pregnancy. Coming to appendicitis. So if you want to, what is going to happen to the appendix in pregnancy? Is it the same or some changes are going to happen? Appendix, is it same, everything same or anything different? So they have asked for you, it is shifted up and laterally. Why? Uterus is going to push it. So once the uterus pushes it, the appendix is going to shift above and laterally. Remember that point. So if you want to do appendicitis surgery, when do you want to do? Always anything second trimester. As the uterus grows up, that's why the important thing is in appendicitis, if the patient presents with pain abdomen, normally where do we check for pain abdomen? McBurney's point. What is McBurney's point? Medial 2/3 or 1/3? Sure. Medial 2/3, lateral 1/3. Whereas that is in a normal female. Whereas pregnant, the uterus is going to shift. So the appendix will not be in that position. That's why the diagnosis is very difficult for appendicitis. It is going to shift above. Okay. So complications, there can be sepsis, preterm labor, abortion. Treatment is either you want to give antibiotics and wait, or you want to give laparoscopy appendectomy. Antibiotics, wait and watch. Wait and watch or go for surgery. So immediate appendicectomy, treatment is immediate appendicectomy. Laparoscopy if the early pregnancy. Appendicectomy, don't wait until second trimester. I said you second trimester. Suppose if she presents in first trimester with appendicitis, don't ask her to come in second trimester. Do immediate appendicectomy. Okay? Appendicectomy is always an acute condition, the same thing. If it is an early trimester, go for laparoscopy. Later pregnancy, laparotomy. Coming to cholelithiasis, which is very important for you. So, cholelithiasis, what is the typical presentation the patient complains of? Typical surgery. I asked this simple question. What is the typical presentation the patient will present? Pregnant female. Surgery నుంచి కాస్త బయటికి రండి. బట్టి కొట్టేసినట్లున్నారు. How does I know it is cholelithiasis? The first, with one symptom I have to suspect it is cholelithiasis. What is the symptom? No, never flatulence, acidity. It is the most common causes acidity for flatulence. With one symptom I can say, actually I got a call day before yesterday. One patient had one symptom. Then I immediately said go for check her levels. What is that symptom? Only one symptom you need to suspect. Symptom, the patient will have typically one symptom. Someone answered. Yeah, Ramya, you are right. It is nothing but pruritus. The patient presents with simple pruritus. So severe pruritus increasing at the nights, especially palms and soles. So if the patient gives this symptom, the first initially, even though you have got pruritus of the pregnancy, after that you have to exclude cholestasis of the pregnancy. Okay, it is more common, very common. Okay. Then non-pregnant women. Why it is more common than non-pregnant? Why pregnancy causes cholestasis? Why? Why there is stasis of the bile? Yeah, good. It is progesterone which decreases the mobility. And one more thing, estrogen is also going to act on it, increasing the bile acid secretion. Okay, both are going to cause the cholestasis of pregnancy. That's why it is more common in pregnant females when compared with the non-pregnant. So nowadays, remember this marker. Out of this, what you need to remember is, Suppose a patient presents with cholestasis, nothing you need until a patient presents with bile duct obstruction or pancreatitis. In such a conditions only cholecystectomy. But remember the marker now which days we are using to diagnose this cholestasis of pregnancy is glutathione S transferase. Okay, remember this marker, this was asked for you. Glutathione S transferase we are using nowadays as a marker to diagnose cholestasis. So tell me what are going to happen to liver parameters. So which test you will diagnose this? What is going to happen to serum? This was asked for you more than 10 times. Serum bilirubin increases, decreases what? How much it will increase? Either it is direct bilirubin or indirect bilirubin. Always in cholestasis it is direct bilirubin. ఎంత పెరుగుతుంది వివేక్? How much? Very little increase or very high increase in cholestasis? High increase. How much? 50, 100, 1000 breakup. Okay, you want 10, you want 20. Any other options? How much it will increase? Most misguided question this is. Always remember serum bilirubin will not be much increased. Okay, it is never more than 5. It will never cross more than 5. Okay, a patient with cholestasis of pregnancy, even if you do serum bilirubin level, they will never cross more than 5. What is going to happen to SGOT, SGPT? SGOT, SGPT. They are not much affected. Okay, alkaline phosphatase will be raised, not much affected. That's why I told you, remember this marker, glutathione S transferase. They have asked this, so bilirubin what is going to happen? So how do we diagnose then? So bilirubin is not raised and SGOT, SGPT is normal. So then how can I diagnose? Ultrasound. Okay, before that, how can I diagnose? Very important test. Which test you want to do to confirm? In medicine surgery you didn't read at all. Basics. No invasive. Before that, which thing? Online, can anyone answer? Which test you want to do and diagnose? Basic blood test only. Which test? Which other than SGOT, SGOT, whatever what you are going to do? Bile, alkaline phosphatase. Next. Okay, gamma glutamine. Okay, other than that. Okay, inka anta depth lo potunaru. You should answer this then. How do you differentiate jaundice? You differentiating jaundice. This is also one of the point in different. Okay, I'll give chocolate once again. Still, very interesting. అయ్యో అన్నీ చెప్పేస్తారు 5 ఆల్ఫా న్యూక్లియోటైడ్ దాకా వెళ్ళేసి వచ్చారు. ఓకే, విల్ సి. సో a serum bilirubin, jaundice is slight. Okay, SGOT, SGPT, nothing, alkaline phosphatase. What is this? అక్కడ దాకా వెళ్ళారు, ఇక్కడికి వచ్చారు. I should have asked in return chocolate from you. Nothing, no one has answered. I would have got around 40 chocolates today. So bile acids, tomorrow get me every one of you one chocolate. Okay, bile acids, these are all the best tests. That's how we differentiate in cholestasis of pregnancy. It is not the serum bilirubin level. So if the answer contains glutathione S transferase, nowadays it is used, okay, as a marker. Is it recurring? Suppose this previous pregnancy she had cholestasis. Now once again it will recur. Yes, always remember it recurs in subsequent pregnancies. Previous pregnancy, if she had cholestasis, once again she may have the chance of getting cholestasis. What is the treatment? Patient, she came yesterday. I told her I wrote for bile acids and all. So what is the treatment I should give? What name? Yeah, Sharanya, you are right. It is bile acids. So the treatment, coming to treatment, is first give antihistaminics. Cetirizine I gave her, cetirizine to relieve her itching, emollients. If still it has not subsided, if the patient is not comfortable, go for Udiliv, ursodeoxycholic acid. Okay, Udiliv 300 mg BD. If the patient is complaining of cough, then go for dexamethasone. You can give even steroids. But in such a case, when to deliver? Either early, late or continue. Suppose now my patient, she is around 36 weeks. I have planned cesarean section around June 15th. She is a prior cesarean section. So I have planned her section. I have to shift my decision either early or late. How? Or can I do it on same day? She now suppose she is having cholestasis. Everything came positive. Now either I should shift my date to early. So nothing to be worried in cholestasis of pregnancy. Okay, you can continue until 37 completed weeks. Do delivery at 37 completed weeks. It will not make any difference. Oh, it is 7:45. We'll continue with this or quiz. Quiz. This is still very big. These are all systemic conditions. Still, very thing is there. Very much is there. So, you want to continue? Quiz. Okay, you answer 10 questions quiz correctly. I will end the class.